بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are going to discuss the third part of the topic anorectal imaging, and in this part we have many of the lesions occurring in the anal region, and we will not finish the discussion of all of these lesions in one lecture, so we'll have another lecture to complete this topic. We want to talk about the anatomy of the anal canal and to discuss some of the inflammatory and infectious conditions like the anal fissure, the anal fistula, the anal abscesses, polyps, and bilonidal disease. Then we will discuss some of the benign lesions occurring in the vicinity of the anal canal, like the fibroepithelial polyps, the granular cell tumor, the myxofibroma, the leiomyoma, the lymphangioma, and also the neurofibroma. Then we will discuss the squamous neoplasms like squamous intraepithelial neoplasia, squamous cell carcinoma, verrucous carcinoma, and aggressive angiomyxoma. Then there are some of other malignancies occurring in this particular area, like the adenocarcinoma, the Paget disease, and the melanoma, lymphoma, and the gastrointestinal stromal tumors. Then finally, we have two side issues like the hemorrhoids and this syndrome, which is known as the solitary rectal ulcer syndrome. Then we start by the anatomy of the anal canal, and we have three parts of the anal canal: the anal canal itself, the anal verge, and the anal margin. The anal canal extends from the dentate line to the anal verge, and its length is about 4 centimeters. Where is the dentate line? And this is the area where the dentate line exists between the upper part of the anal canal and the lower part of the anal canal. There are two definitions here: the anatomical anal canal and the surgical anal canal. The surgical anal canal starts where the rectum ends, and there is a certain landmark here, which is the puborectalis muscle, and I will discuss this in details. Then we came to the functionally anal canal extends from the anorectal junction here in this particular area at the level of the puborectalis muscle, then till the anal verge. And the anal verge marks the junction between the anal canal and the external hair-bearing skin. This anal verge is the junction between the non-keratinized squamous epithelium and the hair-bearing keratinized squamous epithelium, and the anal verge corresponds to this particular area. Then we have the anal margin, which is an area about 5 centimeter, a radius of 5 centimeter around the anal verge. Then there are two important anal sphincters in this area: the internal anal sphincter, which is made of smooth muscles and represents the continuation of the smooth muscle wall of the rectum. Then the external sphincter, which is made of skeletal muscles and is continuous superiorly with the puborectalis muscle, and then the levator ani muscle. This is an important anatomic details, and I will repeat these many times. Okay, and this is the anal canal, and we have the surgical anal canal and the anatomical anal canal, and the junction between is the dentate line. And here you can see the internal sphincter, and outside the internal sphincter, and you can see the external sphincter. The continuation of the external sphincter is the puborectalis muscle, and after that, when you can see a muscle which diverge to the lateral aspect away from the wall of the rectoanal junction, and this is the levator ani. And actually, the evaluation of the anal canal can be done by many ways. And of course, you know that the best imaging modality for the time being is the MRI. And MRI can be obtained by surface coil or endocoils, and surface coil gives good anatomic details of this area. But the endoanal coils can provide superior anatomic resolution, but they have a slightly limited field of view, and they are also poorly tolerated in symptomatic patients. And you know, this area is prone for fissures, fistulae, abscesses, and many of the painful conditions. Then the best pulse sequence for evaluation of this particular area is the high resolution T2 weighted images, and is obtained in the three directional planes, in the axial, in the sagittal, and in the coronal view. Then whenever you obtain the sagittal image, then you align your axial images and the coronal images along the axis of the anal canal. And this is known as orthogonal axial and coronal imaging. Then you have the direction or the axis of the anal canal perpendicular to the axis. You got axial oblique, which is one of the important pulse sequences for evaluation of the anal fistula. Then, if you are going parallel to the axis of the anal canal, then you having a coronal oblique imaging. That's what we call the oblique orthogonal coronal images, which are very essential for evaluation of the anal sphincters. Then we agreed about the pulse sequences needed, and we will repeat this many times, but you should stress on the T2 high resolution imaging in the three planes orthogonal to the anal canal, axial, coronal, and sagittal. Then you may have fat suppressed images before and after contrast injection. Then, where is the anal sphincter, the internal one and the external one? I already mentioned the difference. The internal anal sphincter is made of the smooth muscles and is a continuation of the rectal wall through the anal wall. And this is an involuntary muscles, and they surround the upper two-thirds of the anal canal, and they are formed of smooth muscles, the continuation of the rectal wall. But the external anal sphincter is made of skeletal muscles, and it surrounds the lower two-thirds. Then there is an overlap between the internal and the external anal sphincter, and it blends superiorly. This external anal sphincter will blend with the puborectalis and then with the levator ani muscle. Then what is the puborectalis muscle? The puborectalis muscle is a U-shaped sling which is connected anteriorly to the pubic bone, and it forms a sling around the anorectal junction and go back to the insertion site. Then if you have the sagittal image, and you will look posterior to the anal canal, and you can see what looks like a mass or of low signal similar to the rest of the skeletal muscles, and this is the that part of the puborectalis muscle while it is going around the anorectal junction. And actually the puborectalis is a marker for the end of the rectum and the beginning of the anal canal. Then if you look carefully also, and you can see these skeletal muscles which represent the external anal sphincter, and above the puborectalis, and you see this muscle curving towards to the sacrum, and this is the levator ani muscle. And sagittal images are very good actually in evaluation of the extent of the disease below the levator ani or above, since the levator ani separates the peritoneal cavity from the perineal area. Then this is the plane of the suspected course of the puborectalis muscle, which separates the peritoneal cavity from the perineal area. Then we have the upper half of the anal canal, which has different blood supply and nerve supply and lymphatic drainage different from the inferior part of the anal canal. And actually these informations be not so important for the radiologist, but it's good to know these findings. The arterial supply for the upper part is from the superior rectal artery, which is a branch from the inferior mesenteric artery. And the venous drainage goes to the superior rectal vein, which goes to the inferior mesenteric vein, and this is portal circulation. The nerve supply is from the visceral innervation of the inferior hypogastric plexus, which is sensitive to stretch. And nodal drainage is to the internal iliac lymph nodes, while the lower part is supplied by the inferior rectal artery, which is a branch from the internal pudendal artery. The venous drainage is to the inferior rectal vein, which drains to the internal pudendal vein, a systemic venous drainage. The nerve supply is somatic innervation from the inferior rectal nerve, which is sensitive to pain, temperature, touch, and the pressure. And the lymphatic drainage goes to the superficial inguinal lymph nodes. Then the MRI anatomy of this area is very important, and the coronal T2 weighted image is the best view in MRI to realize this anatomy. And if you look carefully, you can feel this appearance, which is referred to usually by some reports as a tube in a tube. And you see a tube within a tube. The external part, and this is the external anal sphincter, which is continuous with the puborectalis, then continuous with the levator ani, while the inner aspect represents the anal canal and is surrounded by this internal anal sphincter, which is usually hyper intense in the T2 weighted image, relatively hyper intense to the external sphincter, and there is a very fine fat plane that separates the internal sphincter from the external sphincter. And this is the appearance in the axial image. In the axial image, you see the anal canal, and this is the internal anal sphincter, which is slightly of bright signal, and it also shows evident contrast enhancement if you inject contrast like in this image. Then you see the external anal sphincter and the low signal band between both sphincters represent the intersphincteric fat. Once more, and this is the same tube within a tube. This is the coronal post-contrast fat saturated image for the anal region. You see the anal canal, you see the internal anal sphincter, and you see the external anal sphincter. And above you got the puborectalis, and above the puborectalis you got the levator ani muscle. The external sphincter is composed of three parts: the deep part, the superficial part, and the subcutaneous part. Once more, this is the anatomy of the anal canal. Then you see this is the rectum, and this is the junction between the rectum and the anal canal. This is the internal sphincter, and this is the external sphincter. The external sphincter is continuous above with the puborectalis muscle, which is continuous with the levator ani. Then in the sagittal image, as I have mentioned before, if you see the anal canal and you look posterior to it, then you may see these multiple low signal structures representing muscles, and these muscles are from above downward. The one which is above is the puborectalis muscle, and the three components below it are the deep, superficial, and the subcutaneous parts of the external anal sphincter. You may feel that you got some difficulties looking to the sagittal image, but after a while you will see it's very beneficial in evaluation of different pathology in this particular area. Then if you look to this muscle going away from the rectal wall, and this is the levator ani, and here you can see the site of the levator ani. Now, starting by diseases of the anal canal, and the anal fissure, as you all know, is just a tear in the lining of the mucosal lining of the anal canal, and this fissure may cause severe pain and bleeding either during or after the bowel movements. Then the most classic site for the anal fissure is exactly posteriorly in the midline, and in most of the cases the fissure heals spontaneously, but sometimes it may need surgical interference. The causes of anal fissure includes chronic constipation or frequent diarrhea, straining during a childbirth or bowel movement, inflammatory bowel disease like the Crohn's disease, decreased blood flow to the anorectal area, very tight or spastic muscles of the anal sphincter, and rare causes may be due to anal cancer, HIV, TB, syphilis, and herpes. This is the most typical site for the anal fissure. After a few minutes, you will see that this fissure will simulate exactly the anal fistula. But fistula means that you got two openings, one inside and one outside. But here it is just a defect in the mucosal lining of the anal canal, and it has no track and no connection to the outside. Of course, if it has a track and a connection, then you got a true anal fistula. And this is the site of the anal fissure. If you inject contrast material, it will enhance with contrast. And this is another example where a typical location for the anal fissure, which does not extend beyond the internal anal sphincter. Now we came to an important issue in this area, which is the anal fistula or fistula in ano. And this means that fistula means that there is an internal opening within the anal canal and an external opening at the skin in the perianal area. And this fistula strat may extend across or between or adjacent the anal sphincters. And according to the position of the fistula, there are many of the classifications I will mention. Fistula is usually caused by inflammatory conditions, and there is an accepted theory for this pathology I will mention. The incidence is about 1 every 10,000 of the population with, they said, evident male predilection. The causes may be spontaneous in cases of diverticulitis, Crohn's disease, ulcerative colitis, and TB. Iatrogenic, like post-operative, post-pelvic irradiation, childbirth, pelvic malignancies. The symptoms are variable and they include pain, tenesmus, pruritus, and sepsis. And this is the accepted theory for the formation of the anal fistula, which says that there is infection of the glandular tissue, which is located between the sphincters, the internal and anal sphincters. This will result in obstruction of the of this gland, and it accumulates secretions which are then result in an abscess. And this abscess may drain between the sphincters to the skin, and this is known as intersphincteric fistula. And less commonly, the abscess may extend across the internal and the external sphincters to the ischiorictal fossa, then to the skin, and this is known as transsphincteric fistula. Then, intersphincteric fistula is due to perianal abscess which attracts between the sphincters. Transsphincteric fistula may be secondary to ischiorictal abscesses going through the sphincters, and then you have the suprasphincteric. I will explain after that. Then, in order to write a report, radiology report or MR report, and you should locate the site of the internal opening within the anal canal using what's known as the anal clock, and I will show it to you. And you see, this is the anal canal, and there is a rule which says that if you draw a horizontal line like this, then any of the fistula tract occurs anterior to this line. They are single track with no side branches and so on. But if the fistula occur posterior to this line, then you expect that they are branching and they are going into different directions. Fistulae opening posterior to the transverse anal line are usually tortuous and complex. Then this is the most accepted classification of the anal fistula, which is known as Barks classification, where you got 4 types of the fistulae. The most common one is the fistula going between the sphincters, between the internal sphincter and the external sphincter, and then this is what is known as intersphincteric, which is the most common, about 70% of the fistulae. Then the transsphincteric, which is less common, and this is the fistula which goes across the internal and the external sphincter to the SQ rectal fossa. This is the fistula. This one, it goes across the internal sphincter and the external sphincter to the adjacent ischiorectal or ischioanal fossa. Then I am sorry that this A represents this superficial fistula, which is known sometimes as a mucosal or submucosal lesion, and this type, if it does not reach the exterior, then you call it an anal fissure. Then the intersphincteric one is that fistula tract lying between the internal sphincter and the external sphincter. The transsphincteric is this one going through the internal and the external sphincter. Then the suprasphincteric, and this suprasphincteric fistula starts from the anal canal, going between the sphincters, then going up until it reaches the puborectalis or even cross the levator ani, then curves to go through the ischio anal or the ischio rectal fossa. Then we have the extrasphincteric, which is a fistula tract connecting the skin to the rectum. It has no relation to the anal canal. And this is the rarest type, where you got in a fistula an opening on the skin, and if you follow this opening and you go directly above the levator, then into the rectal wall. And this is the classification of the Park's classification of the anal fistulae. And you have, this is the intersphincteric fistula, which crosses the internal sphincter, passes between the internal and the external sphincter to the outside. Then the transsphincteric fistula is crossing the internal and the external sphincter into the ischioanal fossa to the outside. Then the suprasphincteric fistula crosses through the internal sphincter, then in the intersphincteric space until it reaches the puborectalis. If it reaches the puborectalis, and this is enough for the name suprasphincteric fistula. But if it goes up above the levator ani, this is also a suprasphincteric fistula. The last type, which is an extrasphincteric fistula, and this fistula tract connecting the outside directly to the rectum above the level of the levator ani. Then we have two common types and two rare types. The intersphincteric fistula, which is the fistula tract running between the internal sphincter and the external sphincter until it reaches the outside. And sometimes it may have a very small extension through the external sphincter to reach the external opening, and this is considered also intersphincteric. Then the extra sphincteric or the transsphincteric fistula is the fistula crossing the internal and the external sphincters, going to the ischioanal fossa, then to the skin. Then the rare types are number one is the superficial fistula, which usually it is just an anal fissure, and if it is complicated by a tract and this tract gets its way to the outside, it is known as a superficial or submucosal fistula. Then the supralevator or the suprasphincteric fistula is a fistula going through the intersphincteric space until above the puborectalis or the levator ani, and it goes down through the SQ anal fossa to the outside. The last one, which is an extra sphincteric fistula, where you got an opening in the external around the anal opening, and the tract passes through the SQ anal fossa until it crosses the levator ani and connected to the rectum. Then this is the classification or the grading of the fistula. They consider that the intersphincteric simple one-line fistula is grade 1. And if the intersphincteric fistula is associated by side branches or abscesses, is considered grade 2. Then the transsphincteric fistula simple 1 is grade 3. If the transsphincteric fistula is associated with abscesses or side tracts, and this is grade 4. The suprasphincteric, the supralevator or translevator is grade 5. Then one of the old techniques for evaluation of the anal fistula is to inject contrast material through the external opening, and you have films to identify the fistulous tract, its connection to the anal canal or rectum, if there are abscesses, if there are side branches. And this technique is now considered extremely unreliable and is difficult to interpret in view of the new classifications. Then this technique may fail to outline the side tracts because the tracts are occluded by pus or granulation tissue. It also cannot identify the relation of the fistula to the sphincters, whether it is intersphincteric or transsphincteric, and so on. Then we used to put a marker on the skin where the fistulous opening is present. Then we introduce a soft rubber or plastic cannula into the external opening, injecting contrast material, and you can see the connection of the fistulous tract to the anal canal at the 3 o'clock position, with delineation of the anal canal and rectum above. Then ultrasound is also one of the techniques that can help in the diagnosis of anal fistula, and there are 3 methods for ultrasound: the endoanal, the transvaginal, and the transperineal ultrasound. Sometimes they infuse hydrogen peroxide into the external fistulous opening, which will lead to hyperechogenicity inside the fistulous tract. Also, the Doppler facility of ultrasound may demonstrate hyperemia of the active fistulae, which is also demonstrated if you inject contrast material on MRI. Then, endoanal ultrasound is less sensitive than endoanal MRI, especially for deep the supralevator disease. Then I have mentioned before how to examine the anal canal by MRI, and this is the suggested protocol for evaluation of a suspected anal fistula. And we should have 3 millimeter slices, and we should have the axial, sagittal, and the coronal T2 weighted images. Then we have axial and coronal T2 with fat suppression. Then we have axial and coronal T1 fat suppression after injection of contrast, and you should have the sagittal T2. Then we should have axial, sagittal, and coronal high resolution T2. Then we should have axial and coronal T2 with fat saturation. Then we should have axial and coronal T1 with fat saturation after injection of contrast material. Then the anal fistula will appear of relatively low signal in the T1 weighted image, and it will show high signal in the T2 weighted image because of the fluid present inside the fistula tract. And if you inject contrast, it will show enhancement, which indicates that the fistula is active. And the fistula, whenever it is old or healed, you got low signal in the T1 and the T2 weighted image with no contrast enhancement, indicating the development of fibrosis. Then, what are the items that should be included in the radiology report of a perianal fistula? Number one, it should indicate or detect the primary fistula tract and its activity. The activity is judged by enhancement if you inject contrast material, or by Doppler examination if you detect vascularity. Then you locate the site of the fistula, whether it is on the right or in the left, and the course with relation to the sphincters, if it is intrasphincteric or trans or suprasphincteric or extrasphincteric. Then you measure the distance between the internal opening and the external opening. You measure the distance of the fistula tract. Then you should locate the position of the internal opening using the anal clock. Then if there are side tracts or abscesses, you should mention, and you should detect the cranial extension above the levator ani. These are the items that should be included in the report. This is the anal clock, where you imagine that the anal area is similar to a clock. And if the fistulous opening is here, and you mention at 3 o'clock, is here at 4 o'clock, and so on. Then we start first by the intersphincteric simple fistulous tract, which is classified as grade 1. And you see here, there is a linear tract of relative bright signal, because this is T2 weighted image and a coronal image. And there is an internal opening at the 6 o'clock position approximately, and an external opening also in the same track. And this is the internal sphincter, and this is the external sphincter, and you consider this as a intersphincteric fistula. Then actually, when you are going to interpret the MRI for fistulae, I would like to start first by the axial T2 weighted image. Then the value of the axial T2 weighted image is to see the internal opening of the fistula. Then you move the images until you got the external opening, which will be in a different section, of course. Then you say that the internal opening is about 10 at 10 o'clock position, and you do not mention the external opening using the anal clock, but after you identify the internal and external openings and the relation of the fistula to the sphincters, go to the coronal T2 weighted image so that you can see the track of the fistula, and you measure the distance between the internal and the external opening. And sometimes they use this MR fistulogram. They inject contrast material before doing the MRI. This will enhance, of course, the appearance of the fistula, which in this patient had an internal opening at approximately at 4 o'clock. And many times this intersphincteric fistula may cross the midline to form this known as horseshoe extension along the posterior aspect of the anal canal. And this is another example. And here you can see the what is known as the horseshoe fistula, and this fistula is located between the internal sphincter and the external sphincter, so it is intersphincteric fistula and is classified as grade 1. This is not considered a branch of the fistula, because if there is a branch, and then this will move the grading from 1 to 2. But this is not, the horseshoe is not considered a branch. Then without contrast injection, you may not be able to identify if this fistula has an abscess formation or not. But if you inject contrast material, this is a different example where you see an intersphincteric fistula at 7 o'clock. And if after injection of contrast, you got a marginally enhanced lesion, and this is an abscess. An abscess or side branch make the grading grade 2 instead of grade 1. But in this case, the abscess is very well delineated here, and you see a horseshoe abscess posterior to the anal canal and enclosed between the sphincters, and the abscess is of relative bright signal in the T2 and shows intense post-contrast marginal enhancement. And this is another example of an intersphincteric fistula with abscess formation. And you see the horseshoe appearance of the fistula. You see also the abscess formation, and if you look carefully, you may see that this is the internal opening of the fistula, which is approximately at 7 o'clock position. Then you feel that many of the fistula tracts may have variable sized abscesses, small or large. And I thought that this is the good time to talk about the perianal abscesses. And perianal abscesses are in an abscess, which is an inflammatory collection in the perianal area, and this abscess is frequently associated with perianal fistula. The grade 2, which is intersphincteric with abscess, and grade 4, which is transsphincteric with abscess formation. The causes or the associations for this inflammatory condition are diabetes, Crohn's disease, infection, trauma, anorectal cancer, and radiation therapy. And trauma may result in mucosal injury and obstruction of the anal glands, causing the development of an abscess. And this is an example of you should know that anal abscesses may be associated with fistula and may not be associated with fistula, and you got only an abscess which is located in the intersphincteric area, and here you can see the opening of the abscess into the anal canal, but this patient had no fistulous opening externally, and this is the T1 with fat suppression, and you see the relative high signal of the wall, and if you inject contrast material, you see the enhancement of the wall as well as the extensive inflammatory changes. This is the sagittal view, which is very good to judge the extent of the fistula in relation to the levator ani. And here you see this is the levator ani muscle, and the abscess is totally inferior to it, meaning that there is no translevator extension. And this is another example of a big abscess in the perianal area that has crossed the internal sphincter and the external sphincter as well, and extended into the SQ anal fossa. If you inject contrast, then you can see multiple loculi with marginal enhancement, and this is the coronal images where you see that the anal canal is pushed to the right side, and you got multilocular abscess formation in the perianal area inferior to the levator ani muscle. Then here you see also another abscess, which is the result of an intersphincteric fistula arising at 2 and 7 o'clock. Actually, here you may feel some difficulties to identify the site of the openings, but if you look carefully here and you see these two very small dots or black dots, they represent a tube, and this tube is known as Seton tube. And this tube is actually very useful in the management of anal fistulae, and I will mention its exact function. Then these are the openings at 2 and 7 o'clock, and you got this abscess filling the area of the ischioanal fossa, reaching inferiorly to the skin. Then if you would like to know the relation of the fistula to the superior extension, you should go to the coronal images. And here, this is the coronal images. You see a big abscess, and this is the levator ani on both sides, and this is the sagittal beautiful image. You see the levator ani, and you see the abscess below it. But if you inject contrast material, you can feel that the inflammatory changes have also affected the levator ani, which is enhanced compared to the opposite one, but abscess itself does not go above the levator ani. And this is the Seton tube. You see the openings is put into the openings of the fistulous tract at 2 o'clock and about 7 o'clock. And this is a big multilocular perianal abscess with air fluid level in a diabetic patient. And you know that the diabetics are liable for such infection, which may be at times more severe. And in the sagittal image, you see that the abscess is still below the level of the levator ani. And this is the levator ani in the coronal images, the air in the abscess cavity, and this is T1 post contrast fat suppressed images. Then we came to the transsphincteric fistula, which the fistula tract crosses the internal sphincter and the external sphincter. And this is a good example where you see the internal opening at 6 o'clock position, and you see the tract bathing through the ischioanal fossa until it will reach the skin. The track will show bright signal in the T2 weighted image due to the presence of inflammatory collection, and it will enhance after injection of contrast. And you are sure now that this track does not contain abscesses, and this is grade 3 transsphincteric fistula. Another fistula, which is transsphincteric, and you see that the fistula tract has crossed the internal and external sphincter to the ischioanal fossa, and this is the internal opening of the fistula, and you got some extension between the sphincters. Then you got a crossing to the external sphincter as well. And this is another example, and you see this is the intersphincteric fistula, the opening at 6 o'clock, and it goes like this between the sphincters until it pierces the external sphincter and goes into the ischioanal anal fossa. Another example, and you see a fistulous opening at 2 o'clock, and it goes like this between the sphincters until it crosses the external sphincter and minimally extended into the ischioanal fossa. Another example, and this is T2 fat set, and this is T1 fat set after contrast, and you see the fistulous opening crossing both sphincters and the external opening here. If you inject contrast material, and you can see enhancement of the fistula. Then this is a transsphincteric fistula that has connected to the vagina. And here, if you look carefully and you see, this is the internal opening of the fistula approximately at 7 o'clock. Then the fistula has two branches. A branch like this, which is going to the right side, and another branch which is going to the left side. And I think in the grading of this fistula should be 4 instead of 3. Then, if you follow the track on the right side, if you follow this track, and you will got that this is the vagina, and you will got some connection between the track and the vagina. Actually, look to the beautiful sagittal image. This is the fistula tract, and this is the vagina, and here you can see the very subtle connection between both. Then the right branch has connected to the vagina, and the left one has ended into this collection. Then, if the fistula is associated with an abscess or side branch, then you consider grade 4. Here we have an internal opening at 6 o'clock, and this is the track of the fistula going through the external sphincter. And then in the coronal images, you can see the crossing of the external sphincter and the passage of the track through the ischial fossa, ending in this collection, which has elevated the or upgraded the grade of the fistula to grade 4. And I repeat that you cannot say for sure that this collection is an abscess without injecting contrast material. Then here you see an in a fistula of the transsphincteric fistula, and you see that is crossing the midline in the coronal images. And here, this is the internal opening of the fistula, which is almost at 3 o'clock position, and crossed the midline to the opposite side, as well as crossing the external sphincter into the ischial fossa. And this is a transsphincteric fistula, which has extended above the levator. And this is very easy if you look to the coronal image. And this is the external sphincter that has been crossed by the lesion. And this is the levator ani that has been crossed by the lesion. Then you got a complex fistula, and this resulted in a collection, looked like an abscess, and this abscess has extended across the sphincters as well as above the levator. Another example of a transsphincteric fistula, and you got two openings of the fistula tract, one at 2 o'clock and other one at 11 o'clock, and this fistula arches along the posterior aspect of the anal canal with extension in the ischial fossa to the external opening. Then, what is the relation of this fistula to the levator? And you go to the sagittal image, and you can see that this is the site of the levator ani that has been crossed by this abscess, meaning that it is a transsphincteric fistula grade 5. Then here you got a fistulous opening almost at 4 or 5 o'clock, and this fistula has crossed the internal and external sphincter, resulting in a collection in the left ischial fossa surrounded by extensive inflammatory reaction. And here you see the fistula tract along its whole course, and you can measure the length of the fistula tract in the coronal images or even sometimes in the sagittal images. Then this is a supralevator fistula, and you know that supralevator fistula is grade 5. The internal opening is at the 6 o'clock, and it has two branches, a right one and a left one. Then if you follow the right one and you go with the branch, then you can easily appreciate that there is part of the fistula above the level of the levator ani. But if you actually you look here, and this is the sagittal image, and this is the fistula tract, and this is the levator ani, and you got part of the fistula below the levator and another part above the levator. And then this is another example of supralevator fistula, and here is the level of the levator ani, and you can see that the lesion extends above the levator, surrounded by extensive inflammatory material. Another example of the supralevator fistula, and here you see the fistula tract with a right branch between the sphincters. Then if you follow the fistula in the sagittal image, and you can see that there is a part of the fistula tract above, and then this part is crossing the levator, and this part is above the levator. Extra sphincteric fistula is the fistula which connects the skin to the rectum, going through the levator ani, and this is the rarest type of the fistula. It has no relation to the anal canal except for the external opening. Then the fistula passes, as you can see, it crosses the levator and it's connected to the rectum, and there are extensive inflammatory changes and some abscesses in the perirectal area, together with marked thickening of the rectal wall and enhancement. And these are two examples actually of a translevator fistula on the right side and a simple intersphincteric fistula on the left side by contrast enhanced MRI. This is an intersphincteric fistula between the internal and the external sphincters, and this is the transsphincteric fistula. The fistula starts here and goes up, then and you see in this image that it has crossed the elevator, and its continuation is an abscess in the left, in the right SQ anal fossa. And this is also another example of a transsphincteric fistula or transsphincteric abscess, and there is no connection to the exterior, but here you see an abscess collection that has extended. You see this is the levator on the right side, and the levator has been crossed by the abscess, and the abscess has a collection here, and a track, or what looks like a track, which enhances significantly with contrast, connecting this abscess above the levator to this abscess in the SQ anal fossa. And this is the suprasphincteric fistula. You follow this arrow where you got the fistula between the sphincters, and then the fistula has crossed the external sphincter and have two directions. One direction above, above across the levator, and the other direction into the SQ anal fossa. Look for this, and here are the tracts for the fistula. Actually, you will feel some difficulties in the interpreting the anal fistulae, especially in the complicated cases. But if you persisted learning such an area anatomically and pathologically, then you will have your own experience in your own reporting type for this particular disease. Then one of the complications of the fistula is that a malignancy can develop on top of the fistulae, especially the chronic ones, especially those which are related to the Crohn's disease. Carcinoma arising from the anal fistula in patients with Crohn's disease is considered rare. The tumors are either the squamous cell carcinoma or adenocarcinoma, and they develop in a long-standing perianal fistula. And at the time of diagnosis, the tumor is at an advanced stage. The symptoms are non-specific, but the only finding on imaging is that you can see a mass or an enhancing tumor tissue in the region of the anal canal, and this will suggest the possibility of malignancy. And this patient had Crohn's disease for 25 years, and recently he developed perianal painful mass associated with suppuration and recurrent fistulas. And the MRI showed a big mass that is heterogeneously enhanced, and it proved after surgery to be mucinous adenocarcinoma. And this is another example of a patient with long-standing Crohn's disease. She has got a mass in the along the course of the fistula, maybe previously, and the mass is heterogeneously enhanced, and it proved to be malignant. Then this is the seton tube I have mentioned before, and this tube is a rubber tube, and it contains the lumen. And this tube is inserted into the fistula to keep the fistula open. And you know that if the external opening is closed, and the pus will and the inflammatory material will be retained within the fistula, then the development of abscess is sure. Then the problem is now more complicated. So it is better to keep the external opening of the fistula is open until you decide what to do for the patient. And also this seton tube may be used for the treatment of some of the fistulae, and at that time it is called the cutting seton. And this cutting seton is just the same tube which is placed in the fistulous tract, and you got the two ends of the tube and you tight them. And after some time you may induce more tightness of the seton tube, and this will as written here, periodically tightened to pull the fistulous tract slowly to the outside. You mean if you tighten the tube, you got the tube towards the outside, and its original place will heal by granulation tissue. Then the next time you tighten it more, and you got the tube to the slightly to the outside, and its original place will heal by granulation tissue, and this will slowly direct the fistulous tract to the outside away from the sphincters, and this will reduce the risk of fecal incontinence if you decide to do some surgery. And this is also a short video to show you how this seton
This
tube
male
can
patient
be
has a long fistula tract in the right buttock
useful
at
and
8 o'clock
used
position.
for training.
The patient is put in prone jackknife position. The tract is thoroughly carotid. The external opening is widened. The tube of required length is measured and put in the tract. The tube is not sutured to the skin. During post-operative care, the tube is taken out before every dressing. The tract is cleaned with a cotton swab mounted on an artery forceps. After the tract is cleaned, the tube is put again. As the deeper tract starts healing, the length of the tube can be shortened gradually. After the deeper tract heals, the tube insertion can be stopped.
Okay, then you understand the value of this hidden tube, and sometimes whenever you perform an MRI, you can see the tube as low signal dots because of the air inside the tube itself, or and you can see the crossing of the tube through the fistula. One of the important issues is after treatment of the anal fistula, and you got some granulation tissue and fibrosis at the site of the healed fistula. If you inject this granulation tissue with contrast, it will enhance. Then you should discriminate between if there is residual activity in the fistula, or there is abscess, for example, or this is just a healing granulation tissue at the site of the fistula tract. This is very important, and you can also have some information from the T2 weighted images by identifying some fluid signal within the tract. This means that there is active remaining activity, but if you got total low signal at the site of the fistula, and also this fibrous tissue, whenever it matures, it will not enhance. But in early stages, if it is still immature, the fibrous tissue will enhance. Then we have two remaining topics, and we'll stop after that. Then the remaining part, which will deal with the tumors of the anal canal, will be a separate talk. Then by the name inflammatory cloacogenic polyps, and these are the inflammatory pseudo polyps seen frequently with Crohn's disease, ulcerative colitis, and so on. And these polyps, you know now that Crohn's disease is one of the lesions that can affect the anal canal and do many complications. But if you remember from the GI lectures, they taught us that ulcerative colitis is that disease which affects the rectum and anal canal, while Crohn's disease in the colon is far away in the ascending and transverse colon. But there is a good number of patients with perianal fistula may be caused by Crohn's disease. Then inflammatory bowel disease are more common in women, occurring in the childhood period up to the sixth decade of life. They may represent by bleeding, and they are characterized by tubulovellous pattern of growth with superficial ulcerations. And actually, I failed to get an imaging either CT or MRI for such polyps, but a lot of endoscopic images are available. So, and you see this is one of these polyps, and the inflammatory bowel diseases like Crohn's disease, malabsorption, diverticular, and these conditions also may be associated with adenocarcinoma or human papilloma virus. The diagnosis is by endoscopy and the biopsy. Polyps are in the range of 1 to 5 centimeter, and they may be associated with hyperplastic or adenomatous polyp. I mean, these inflammatory polyps can be present in the same time with these types of polyps. And here in endoscopic and surgical specimen for pseudo polyps, in a patient with chronic ulcerative colitis. Then this bilonidal disease, which is the last issue in this talk, bilonidal disease is a common condition which is occurring in the back, approximately somewhat above the level of the anal canal, and they are typically occurring near or at the upper part of the anal cleft. And this binodal disease is an inflammatory condition in the subcutaneous and the skin of this particular area, which may lead to the formation of abscesses and sinus cavities. Rarely, this pilonidal disease may produce fistula tract. Is more common in men than in women, and is more common also in overweight persons and those with coarse body hair. The age incidence is from puberty up to the age of 40 years. They thought that the causes of bilonidal disease may include a bilonidal sinus that may track down caudally, creating a perianal fistula, and this is a rare or not a common presentation. Or the second is a hair may enter the healing wound of a surgically managed fistula, or the hair may be propelled, penetrating the normal enoderm and producing a foreign body reaction, which is usually observed in the sacrococcygeal region. Actually, we do not need imaging for the diagnosis of bilonidal disease, but imaging is essential if there are complications, and the complications may include meningitis because of the near proximity of the lesion to the spinal canal, osteomyelitis of the adjacent sacral bones, necrotizing fasciitis, and toxic shock syndrome. Bilonidal disease usually present as an abscess in the perianal area, and you can see the inflammation, and this abscess may drain pus to the outside. Bilonidal disease is painful, and the pain is worse during sitting. The discharge may be cloudy fluid or bloody fluid from the affected or the inflamed area. Patient may have multiple openings in the midline or lateral to the midline. This disease has many differential diagnoses. In the first line is the fistula in ano, then hidradenitis and skin fruncle, syphilitic granuloma, tubercular granuloma, osteomyelitis of the sacrum. Then actually bilonidal disease or bilonidal sinus is just an inflammation in the subcutaneous area which may induce a blind tract that is not connected to the inner structures, and this is the sinus. But if you got just inflammation without a tract, and this is known as bilonidal disease. As you see here, and you got in the sagittal T2 fat suppressed image in an inflammatory granulation tissue subcutaneously posterior to the sacrum in a classic position of bilonidal disease. And this is also an example, and you see an inflammatory tract which goes from the skin deep, but it did not reach the external anal sphincter, nor of course the internal anal sphincter, and there is no external opening. This should be carefully discriminated from the perianal fistula. And here you see an inflammatory collection with abscess formation along the back of the sacrum. And this is known as bilonidal disease, low signal in the T1, high signal in the T2, and some buckets of marginal enhancement denoting the presence of abscesses, and this is the appearance of the patient. Hidradenitis is an inflammatory condition affecting the hair follicles, and it is common in the axilla and underneath the breast sometimes, and in the anal area. Sometimes you got multiple collections in the subcutaneous area, and they may show inflammatory signs. And here you can see the sagittal image. This is the anal canal, and this is the external sphincter, and this is the levator ani, and this is the rectum, and this is the prostate. Then hidradenitis suppurativa is known also as acne inversa, is a long-term skin disease characterized by multiple inflamed, painful, swollen lumps that break open, releasing fluid or pus. The most commonly affected areas are under the arms and under the breasts and in the groin. And this is a gross appearance. And here you see a bilonidal sinus, which is of low signal in the T1 and high signal in the T2, and goes in the subcutaneous area. It's very important to differentiate between a bilonidal sinus and fistula in ano. The chronic bilonidal disease is associated with sinus tract. The sinus is almost exclusively limited to the sacrococcygeal area. Bilonidal disease with fistula around the anus is atypical presentation. If you detect fistula's opening, and this is in favor of the diagnosis of fistula in ano rather than bilonidal disease. Bilonidal disease may produce abscess reaching the anus, mimicking an anal fistula. The coexistence of anal fistula and bilonidal disease is uncommon, and of course, still there are certain anatomic locations for both diseases, one in the perianal area and one in the back of the sacrum. Thank you very much. Alhamdulillah.